everyone. My name is Jennifer Pritchett, and I want to welcome and thank you for joining us today for the Zoom presentation sponsored by the Mansions. We're going to go and hear from our guest speaker, Dr. Gary Figiel, who is speaking on COVID and the impact to seniors and their families emotionally and physically. Dr. Figiel is a board-certified geriatric psychiatrist. He received his medical degree from the St. Louis University School of Medicine and completed his internship, residency, and fellowship in the electroconvulsive therapy treatments and neuropsychiatry at Duke University. Dr. Figiel is specially trained in the early diagnosis, management of memory disorders. And after Dr. Figiel's presentation, you'll have the opportunity to ask questions. Also, you can request to receive a recording of today's talk. So now I'm going to turn it over to our guest speaker, Dr. Gary Figiel.
What I'm going to do is talk about the history of what we've learned, what we know and don't know about COVID over the past 12 months, and then leading right up to literally the information that's coming out this morning, and then looking into the future, the next several months, about what we need to learn, what we need to know, and how to what our expectations can be about the new normal and how we're going to be able to socialize safely in the near future. So that all being said, what have we learned about COVID over the past 12 months is that COVID's a virus, and the risk factors for COVID depend, number one, by far the strongest risk factor for having serious side effects and dying from the COVID virus is age. And age by far trumps all the other risk factors. It's by far the most important thing. And that's why the vaccination protocols have heavily favored the elderly and wanting the elderly to get vaccinated first, because they are the most at risk. If you're under the age of 65 and in good health and you contract the disease, the virus, the chances are that you're going to die from it below the age of 65 is probably, it's well below 1%. It's somewhere between 0.25% to 0.5%. So if you're under 65, the chances are that you're going to die from COVID is around 0.25% to 0.5%. And if you look at the other end of the spectrum, if you go up to age 85, the chance, if you contract COVID or get infected with the COVID virus, the chances that you're going to die may be as high as 20%. So we're talking about a 20% risk of dying at the age of 85 versus under 65 around 0.5%, which is a 40-fold increase. So when we're talking about risk factors for dying from COVID, age is by far the strongest and the most serious risk factor. And that's probably related to our immune system not working as well or being as robust and as strong as we get older. Other risk factors that you've heard about, one, are men are more at risk than getting the illness than women. Number two, people that have a history of heart disease, if they've had a heart attack, they're at risk also for getting, they're more at risk for dying from the illness if you have had a history of a heart attack. And then ethnicity, Blacks and Hispanics are also more at risk for dying from the illness if they contract the illness. Other more recent risk factors that have come out are learning disabilities. That's information that's coming out of England. It hasn't been universally validated yet, but people with mild to moderate learning disabilities also appear to be at an increased risk for dying. Why that is unclear. And included in that is illnesses such as Down syndrome. But again, I want to repeat the difference in dying from COVID, the risk of dying from COVID at the age of 85 versus 65 is a 40-fold increase. Whereas all of these other risk factors I've talked about, the male sex, cardiac disease, ethnicity, and the risk that those factors bestow upon you or possibly dying from a COVID virus increases your risk 2 to 4 times. So if you're 65 years old and you don't have any of these other risk factors, your risk again is less than 1%. it's around, let's just say 0.5%. If you're a male, your risk of dying might be 1 to 1.5%. So that's increased from 0.5%. So that's like a 2 to 3%, 2 to 3 times increase. And that's the same also for heart disease. If you've got a history of a heart attack, your risk increases 2 to 3 times. So that would be from 0.5 to 1.5. And the same also for ethnicity, it's around from 0.5 to 1.5 to 2%. So again, all those things are significant, and your risk is increased 2 to 3 to 4 times. But again, age is 40 times the increase. So that's an important thing to learn. That's one thing we've learned and we understand now about the illness. What happens when you get the COVID virus? And again, this might be changing, but up to right now, what can you expect if you contract the illness, assuming you haven't been vaccinated? Over the past year, what we've learned is that 40 to 50% of people, regardless of your age, young or old, are asymptomatic if they get the virus. So 40, 50% of people who have the virus are asymptomatic. And that's important because we've learned that we've heard over and over multiple times now that you can catch the virus from people who are asymptomatic carriers. So 40 to 50% of people who have the virus are asymptomatic. Why those people remain asymptomatic, we don't know yet. Whether it's related to our own biology, our genes, whether we have a stronger immune system, or whether we just didn't have as strong a viral load or a viral concentration. We don't know the answer to that question at this point in time. But 40 to 50% of all people who test positive for COVID are asymptomatic. The next group, around 25% of patients who get infected with the virus, have what we'll call mild to moderate symptoms. Initially, going back a year ago, the symptoms that people were getting in the mild to moderate group, again, around 25% of the patients who were infected, there was some combination of GI symptoms, nausea, diarrhea, along with respiratory symptoms, shortness of breath or cough, but not usually serious enough to go into the hospital in 25% of people. Over the past year, it seems like the GI symptoms have gotten less, and that 25% who are in the mild to moderate group, it appears to be more predominantly just purely respiratory symptoms, and I haven't been seeing as much of the GI symptoms as initially when the virus first came out. Why that is, I don't know. So right now, what I've told you is we're talking about people who get infected. What can we expect, regardless of your age? 50% asymptomatic, 20 to 25% get mild to moderate symptoms. And by that they usually don't have to go to the hospital. And today, predominantly respiratory symptoms, fatigue, a cough, maybe a low-grade fever, and some shortness of breath. And that leaves us with the remaining 25% of people who get infected. What happens to them? They get very sick. And around approximately 1 in 4, 1 in 5 patients who get COVID have to go into the hospital. And the majority of those patients that are going into the hospital are for respiratory symptoms secondary to a pneumonia. So those are the odds, no matter what your age. And I'm not talking about your risk of dying now. I'm just talking about no matter what age you are, that if you get infected with the illness, there's a 50% chance you'll be asymptomatic, a 25% chance you'll have mild to moderate symptoms. And then there's around a 20 to 25% chance you'll be sick enough that you need to go into the hospital. And again, that's usually for pneumonia and for respiratory symptoms. In the group that ends up going into the hospital, the people who I'll say are severely sick, there's 2 waves of the illness that can come on. There's the initially people are going into the hospital for the respiratory symptoms and for pneumonia. So for the first 7 to 10 days, you're predominantly dealing with pneumonia and making sure your oxygen levels are remaining well and that your lungs are starting to heal. There's a second problem that can occur maybe in 10% of patients or 15% of people, that after they get over, they can actually be getting over the pneumonia and look like they're doing better, and maybe even to the point where you're thinking about them being discharged and going home from the hospital. And then a second wave of the illness can come on in people who have been severely ill from the pneumonia. And that's been called the cytokine storm. And that's related in large part to a very, very exaggerated or magnified inflammatory response, again, that occurs in some patients. And we can't yet predict who those people are, but they get a very, very dramatic, severe, significant inflammatory response that can damage many different organs in the body, ranging from the heart to the kidneys and even to the brain. So that can occur maybe in the 25 to 30% of the people who were admitted to the hospital. So that's something to be aware of, because many, many people get through the pneumonia and they're starting to let their guard down and think everything is looking good. And then a second wave of the illness can come in and really have very, very serious effects on some of the patients. So that's where we are, with understanding the risks from the illness and sort of the clinical course of the illness. There's been a fair amount of information that's been talked about whether some people with COVID have persistent symptoms going out 2, 3, or 4 months after you're infected. And although it hasn't been systematically studied yet, my clinical impression is right now that the people who have persistent symptoms, it's more likely to occur in people who were severely ill to begin with, people who were either hospitalized and or who ended up in intensive care units who were on ventilators. And there's some unknown number of patients who were initially severely ill with the virus that 3 to 4 months out after they have the illness are still complaining of a host of symptoms. The most prominent ones are fatigue, some persistent headaches, some depression, and then also some people are reporting some very subtle cognitive problems 3 to 4 months out after they initially were sick. And again, I think we're going to find as we study this group of patients more and more that the patients, I'm repeating myself, but the patients who have that group of patients, again, we don't know how many or what percentage of patients it is. My guess is it's going to be maybe 10 to 15% of the severely ill patients that we're going to find they have persistent symptoms 3 to 4 months out. One study just came out last week that looked at people that were having persistent cognitive problems 3 to 4 months out after they were sick. And the cognitive problems are mainly related to just being able to focus, having attention and concentration problems. So what we call in our field, executive problems, frontal lobe problems. And what the study that was reported last week showed that the patients who had persistent cognitive problems 3 to 4 months out, they drew blood samples on them and they still had elevated inflammatory markers. So again, that's being studied right now. What's the cause of these persistent symptoms and what we can do about it? And one of the studies that's ongoing, that's just starting right now, is whether if these persistent symptoms are related to a persistent prolonged inflammatory response, whether medicines like steroids, which can dampen down and suppress the inflammatory response, whether steroids might be helpful with some of these patients who have persistent behavioral, cognitive, or even physical symptoms 3 to 4 months out. Okay, so that all being said, one of the things that came up, over the past year was, even before the first cases of COVID were reported here in the United States, I was watching what was happening in Italy, and what they report, if you can all remember how badly Italy was damaged and affected and how many people were dying in Italy from COVID before it came over here. One report I heard was that 50% of the patients who died in Italy were patients in nursing homes, so the elderly. So that is, I think, an important point, that was something that was already information that was available out there even before COVID ever hit the shores of the United States. And because of that, being a geriatric psychiatrist, I was starting to prepare myself for this even before it came here. And so we were very, very keen and interested in seeing what the effects of the illness were going to be on our patients. And one of we reported in a paper that was published back last March or April in the American Journal of Geriatric Psychiatry, with my daughter and Dr. Bill McDonald out of Emory, we reported the first cases of how the COVID affected patients with Alzheimer's disease. And since then, we followed a large group of patients with Alzheimer's disease who were infected with the COVID virus. The good news is it doesn't look like that the people with Alzheimer's disease have a higher mortality rate than similar age-matched elderly people. But nonetheless, what we reported back then, the CDC guidelines for COVID were, again, really focusing on fever, cough, shortness of breath, and some GI symptoms. And a little bit later on, they were talking about loss of smell and loss of taste. So what we observed in our Alzheimer's patients, the first group that was infected, was that they were not presenting with any of the original CDC guidelines, such as respiratory symptoms, fever, or the GI symptoms, but they were presenting with declines in their cognition and their activities of daily living. They were more confused, they were more lethargic, and or they were requiring a higher level of care than what had been previously observed. So that was important initially when we observed that, because we were able to start beginning to identify people at an earlier stage and potentially isolating them and preventing the disease from spreading in a lot of our memory care units. Since then, we've gone on to study a large number of patients with Alzheimer's disease that have been infected with the COVID virus. And those findings have held up that for many of the patients, at least half to 2/3 of the patients with Alzheimer's disease are initially, when they're infected, are presenting with symptoms in their behavior or their cognition, and not presenting initially with the fever or respiratory symptoms. And with the general population, there is a number of patients with Alzheimer's disease who are infected with the virus who also are asymptomatic. Around 25-30% of the Alzheimer's patients have no symptoms at all. As with the non-Alzheimer's patients, what we've seen in our Alzheimer's patients who have had more moderate to severe symptoms, they also appear to have a more persistent decline in their cognitive and functional skills 3 to 4 months out. And we've been following a lot of those patients now over the past 3 to 4 months, and are seeing that the patients, probably the ones who were, again, like the rest of infected patients who were more severely ill, are more likely to have more persistent cognitive and functional decline in the Alzheimer's group, which is not surprising, because what we've been reporting and looking at and talking about for the last 10, 15 years, that people with Alzheimer's disease are much more sensitive and prone to medical problems in general. And people with Alzheimer's disease, we've talked about this inflammatory response that occurs in patients with COVID. Well, there is an inflammatory response already going on in the brain of people with Alzheimer's disease. So it's not surprising with an illness such as COVID or any other medical problem that also causes increased inflammatory processes in the body or the brain, that it would make the Alzheimer's disease worse. So we've been reporting for a number of years now that, patients with Alzheimer's disease, when they develop a urinary tract infection, they can look very, very sick. They can have serious decline. People that have with Alzheimer's that have any type of medical problems, ranging from minor things such as falls or even minor urinary tract infections to more serious illnesses such as pneumonias or heart attacks or strokes, that you can see very, very, very severe declines in patients with Alzheimer's disease. And it's probably related to this additional magnification or aggravation of the inflammatory response that's already going on in Alzheimer's patients' brains, that with the additional medical problem, whether it's COVID or some other medical problem, you're going to see additional toxic inflammatory processes going on in the brain of patients, which leads to that persistent problem. Before the COVID virus, what we were seeing in our Alzheimer's patients who got medically ill, the recovery times were variable in our patients with Alzheimer's disease. We saw that so someone with Alzheimer's disease who contracted a medical problem, around a third of those folks recovered quickly and got back to their baselines functionally and cognitively, usually within the first several weeks. another third of the patients would slowly recover their cognitive and functional skills within 1 to 3 or 4 or 5 months. And then the remaining 1/3 of the patients of Alzheimer's who got medically ill and then declined never really got back to their baseline. So I'm thinking we're probably going to see a similar types of recoveries in our COVID patients with Alzheimer's disease, but it's too early to tell now because we haven't had enough time to study all these patients yet. But suffice it to say, as with the non-Alzheimer's patients who get severely ill from COVID, that the same is true for Alzheimer's, that 3 to 4 months out, some of them are having persistent decline. And we'll be able to tell you more about that in the future. So let's talk about the vaccines now. So where are we with the vaccines? What we know from the vaccines is largely based upon the original strain of the virus that came here a year ago. And so all of the vaccines that were developed right now, the Pfizer and the Moderna particularly, that we've been getting injected with here, there are other vaccines around the world, but the majority of the people in the United States now are getting the Pfizer and the Moderna. Those were tested against the original strain of the virus. And what those studies showed was that the vaccines appeared to be very, very effective in either preventing symptoms or preventing serious progression of the illness, possibly up to 94% effective in preventing serious disease, which is very important because I said without the vaccine, what we were seeing was 50% of patients were having 25% mild to moderate symptoms and 25% moderate to severe symptoms, with the mortality rate of close to up to 20%, if not higher, in patients over the age of 85. So if the vaccines truly are 94% effective in preventing the disease, that's going to be quite an accomplishment. And we still are going to need to learn, again, the longer that we're studying these viruses, and now that people are getting vaccinated, we're going to have more and more information about how effective they are. Some good news that came out today, literally, the country of Israel's had a very, very aggressive vaccination program in place now. And I think they've been leading the world as far as the percentage of their population that's received both of the vaccination shots. And they just this morning released some information that they compared a very, very large number of patients. I believe it was, I don't want to say the number, but it was hundreds of thousands of patients who had received both of the vaccination shots and compared them with the patients who were not vaccinated. And similar to the original studies, so this would be called a real world study versus a pharmaceutical study. What they showed was in Israel that, again, 94% effective. And again, we need to, as time goes on, we're going to define what effective means. Does it mean no symptoms at all? Does it mean it prevents us from dying or developing or serious problems? And even more importantly, what we're going to be answering too, does it prevent you from being a carrier of the disease? There's a question that's being raised is whether if you've been vaccinated and you are safe from getting sick, but whether you might still be a carrier, whether you could still have some virus in your system that you could possibly transmit to other people, even though you're safe because you've been vaccinated. And those are all questions that we still don't know the answer to. But the good news is that came out of Israel today, that in a real world study with hundreds of thousands of patients, that the vaccines were 94% effective compared with the patients who were not vaccinated. So that's really good news that came out today. Now, the thing that we have to really be careful with now is that, as with any virus that occurs in nature, the reason why we have to get a flu shot every year is for a couple of reasons. One, whether the immunity from the vaccine lasts beyond a year is one question. And that also goes to another thing we don't know the answer to. How long are we safely immunized once we get vaccinated? So how long are we? So we're 94% less likely to get sick if we're vaccinated, but how long does that last for? And we don't have the answer to that question yet. because the studies started, approximately last May or June. So we maybe have data now that's growing on a daily basis of people who have been vaccinated now for 7 or 8 months. And we're literally learning day to day how many of those people are staying well. So we're going to learn that more and more over the next 3 to 6 months, how long these 2 vaccination shots that we've gotten, how long does that protect us from the initial strain of the virus? But the other potential problem that's been developing, as with any other virus, one of the reasons why we get a flu shot every year is because viruses change or mutate every year. And the influenza shot is slightly tweaked or adjusted every year to adapt to whatever changes or mutations that have occurred in the virus. So it's not surprising, nor should it be overly alarming, that there are now a number of strains, maybe up to 7 to 8 or 9 different strains around the world now that are slightly different from the original strain of virus that the vaccines were developed against. And the big $1 million question is, a couple of them, how safely or how effective is the vaccinations that were received going to be against these other strains of the virus? And the answer is we don't know the answer to that question right now. So what we're going to need to be looking for, and particularly when you say how effective it is, again, how effective potentially is the vaccines that were received going to be against these strains? Number one, does it protect us from getting the virus entirely? 2, there's some evidence that's already showing for one of the strains, the strain in South Africa, that some of one of the vaccines, the AstraZeneca vaccine, did not appear to be very effective in preventing mild to moderate symptoms. Apparently 45 to 50% of the patients in South Africa who got infected, who were vaccinated, developed mild to moderate symptoms. But we're hoping in the preliminary observations, again, we don't know the answer yet, is that even though they were mild to moderately infected, we're hoping that we can reduce or very effectively prevent the moderate to severe cases, which we were seeing in 50% of the patients who were infected with the virus initially, like I told you about earlier in this talk. So that's information we're going to be keeping an eye on. So there's 3 strains that really we have to keep an eye on. And when you're listening to the news, there's a strain out of South Africa, which has been in South Africa at least for the last couple of months. And apparently around 90% of all the cases in South Africa now are from the South African variant. So information is going to be slowly coming out, hopefully not too slowly, but information is going to be coming out of South Africa over the next 1 to 3 months about how effective the vaccines are against preventing the South African strain. About very, very little information, both scientifically and clinically, has been coming out of South Africa. So very little is known about it. There's only been a handful of cases of the South African virus variant that's been reported in the United States so far. The other strain, which is in England, which has also been prevalent in England for the last couple of months, it goes under different names, but it's been called the Kent strain, like Clark Kent, Superman, Kent. It's been available, or it's been infecting people in England now for the last couple of months. But England's been a little bit behind us in their vaccination program, so they haven't had enough time to tell yet whether the vaccination is effective against the England strain. And then 2, we also are lacking still in the clinical profile of the people with the English strain and the South African strain. Like the numbers I gave you initially, 50% asymptomatic. This is what the original strain, 50% asymptomatic, 25% mild to moderate symptoms, 25% with severe symptoms. We don't know that spectrum of disease severity yet with any of these strains. And so that's what we're going to be looking for very, very carefully over the next 1 to 3 months. As we right now have people who have been vaccinated twice now, what I'm going to be looking for very closely in our patient population, all the patients that we're following in the assisted living facilities. And if more than a sporadic, isolated case of someone who gets infected after having their vaccination, after having both vaccination shots, becomes reinfected, then that's going to be a red flag, possibly whether these new strains are able to outmaneuver the vaccines, and the vaccines aren't working well. So that's all a work in progress, which we don't have an answer for right now. But again, it's something that hopefully we're going to have a clear-cut picture for over the next 1 to 3 months. The good news is, what I reported, what happened in Israel today. Israel's been under such a severe lockdown, though, over the past several months. I doubt that they've had a very large exposure to any of these other strains. So it's very likely that the good news that came out of Israel today most likely reflects the efficacy of the vaccines against the original strain. The other good news, potentially good news, again, we just don't know, that although this English strain has been in England now for the last couple of months, England's been under very, very severe lockdown too over the past couple of months, much more than in the United States, that their numbers have not been going up, they've been coming down, which suggests that the strain is manageable and or possibly that the vaccines are working against it. But again, we just don't know. So that's where we are with that right now, is just really keeping a close eye on what's happening here. I'm a little disappointed that the United States is not taking a bit more of an aggressive approach at monitoring and watching these strains and seeing how common they are here in the United States. And let me tell you what I mean by that. So whenever you get tested for COVID virus and they do the nasal swab on you, what that tells you, the results of that test tell you that you've been infected with one of the strains of the virus, but it doesn't tell you which strain. So the only way you can tell which strain you've been infected with is literally the nasal swab needs to be sent to the CDC, and the CDC does a genetic analysis on your nasal specimen, and it takes them a couple of days to actually do the actual genetic sequencing to be able to tell you which strain of the virus you have. And I've been really asking around a lot about how closely that we're looking for these other strains in the United States right now. And the only answer I've come up with so far is that there is some type of surveillance protocol in place in the United States right now, but we don't really know. I really don't know how regularly they're checking for these other strains. Certainly, if somebody gets reinfected after they've been vaccinated, you would think there should be a protocol in place where all those people, after they get reinfected, that these samples are sent to the CDC. I'm not sure what the capacity of the CDC is to monitor all this. And again, I'm a little disappointed that it's not being more aggressively monitored. It's only at the CDC that they can tell you what the strains are. You can't, even at some of the top hospitals in cities such as at Piedmont, St. Joe's, and Northside, they don't have the facilities or the equipment to tell you what the strain is that you might be infected with. So again, we're going to be watching that very, very carefully. That all being said, what should we do now if we've had our vaccines? Again, I would just be looking very, very carefully at the numbers. The numbers are coming down across the country, which is good news. That's in part reflected by the people are starting to get vaccinated. I think as of last week, around 40 million people in the United States have been vaccinated. Around half of those, maybe 15 million or so have received both doses of the vaccine. So it's starting to happen. And that's going to be bringing the numbers down. And I think also we've been overall done a pretty good job of social distancing and wearing masks. So I think what we need to look for, and everybody's asking the question, well, when can we start returning to normal? And again, I think it's going to be a slow return to normal over the next 2 to 6 months as we learn more about how careful or cautious we have to be about these new strains of virus. They're already working on a booster shot for the vaccine for these new strains, which apparently may be available by the fall. So that's good news. So even under a worst case scenario where the new strains are not that effective against the vaccine, we're going to have hopefully another booster shot available in several more months to help against the strain. And it's possible that might be the routine over the foreseeable future, is not unlike the flu shot, that we're going to be needing annual, or who knows how often, annual booster shots to prevent against, prolong our immunity and or to prevent us against newly evolving strains of the virus. A lot of the questions that we're asking about what have been the effects of this whole socio-cultural phenomenon we've been through the past year, beyond being infected with the virus, but what have been the effects of quarantining and isolating on the elderly. And again, it's obviously a very complicated question and a complicated answer. If you've ever taken any statistics classes, there's something in statistics that's called a cohort effect, which means whenever you're asking a question about people, the answer to that question is going to vary from one generation to the other for various reasons. One for socio-cultural reasons, economic reasons, and possibly even for genetic reasons, as our bodies and our DNA is changing over time. But again, I think the population that we're dealing with right now, the elderly, which is, I think you can make a strong argument, has been exposed to many, many more difficult times in the past than the baby boomers have and some of the newer generations have. They've been exposed to great economic stressors like the Great Depression and the World Wars, and economic problems and the racial problems we've all had over the years. So I think when you take that cohort into effect, prior to COVID becoming a problem, I was always very, very impressed with this generation of elderly, that how sturdy and strong they were and how much they treasured life and how they never wanted to give up. I mean, I always used to see, many, many people who were severely ill and dying in this generation of the elderly, who were severely ill and dying, and they wanted, the majority, vast majority, 95 to 99% of those folks that I've been taking care of and had the honor of taking care of over the past 25 years, that, the number of people that really give up and don't want to live anymore, even in spite of severe problems, whether medical, cultural, economic problems, they want every last moment of life. And so again, when we talk about the cohort effect, again, I think this generation is probably better suited and stronger to adapt to such an epidemic and quarantine isolation than possibly some of our younger generations, but time will tell. That being said, though, still it's been very, very difficult. And again, I think in a number of patients that we've seen, I mean, certainly depression is rampant, whether you had COVID or not. There's data that people that have been infected with COVID have, 3 to 6 months out, or 30 to 40% of those patients are experiencing psychiatric problems ranging from anxiety disorders to PTSD to depression. Certainly in our practice, the patients that have been in assisted living facilities under isolation and quarantine and deprived of contact with their families and their friends, and not being as physically active and exercising as much as they have, certainly the occurrence of depression has gone up significantly in the assisted livings that we've been working with, probably as high as 30 to 40%. I just yesterday took a peek at some data I got from one of the assisted livings that I work with, where I looked at data comparing mortality rates in the assisted livings between 2019 and 2020. And again, it was a little bit surprised that outside of the effect of COVID, there was not a right out of the gates. Again, I haven't analyzed the data as closely as I would like to, but just look at comparing mortality rates at this one assisted living facility group of 6 or 7 communities, that there wasn't a a large increase in mortality rates outside of what you might expect from the COVID virus, increasing the mortality rates a degree. So it hasn't been that large, at least in the preliminary data, but still we're getting case reports, at least around the country, of people dying from failure to thrive. How much of that's related to undiagnosed depression? And again, depression has gone up significantly. And again, the untold effects of, I can tell you some really sad cases of people during this time. I've had at least 4 or 5 cases just in my practice of people that died not from COVID, but they died because of COVID, where they didn't get the level of care that they would have gotten without the restrictions we had placed upon us because of COVID, not being able to go to the emergency rooms, families deciding not to send their loved ones to the hospital because they couldn't visit, fear of getting infected in the hospitals. So I've had at least 3 or 4 patients that died from depression that normally would have not died because they didn't get the proper medical care. And then I've had other people with medical problems ranging from pneumonias to other types of medical problems that normally would have survived, but did not get as aggressive medical care that they would have received in quote unquote normal times. So you've heard about, we're beginning to talk about these other deaths, not caused by COVID, but indirectly caused by, not directly caused by COVID, but indirectly caused by COVID, which are all going to be in effect. And again, just to throw in, which is not really part of the topic here, I am, being a neuropsychiatrist, I am severely, as you all are, I'm sure, but just from a brain development, neuropsychiatric standpoint, I am just deathly worried about the effects on our kids now of over the past year, going on now a year and a half, potentially, of not going to school and the lack of social stimulation and the lack of physical exercise, that the potential effects this is going to have on this generation of kids. And we're not going to know the answer to that for gosh knows how long, for another decade or two. But I am just severely, severely worried about that. So that all being said, I think we've got time. We've got around 10 minutes left. So I want to open up for any questions on any topics which I haven't covered here. Hopefully I covered most of your questions.
What is the likelihood of a strong reaction to the second Moderna shot? I heard not to take Tylenol or Advil before the vaccine, as it might interfere with creating antibodies. Also heard to delay taking any medication or Tylenol and Advil 6 hours after. Right.
I don't know how good that data is, but that's what they're recommending. It's around, both with the Pfizer and Moderna, I think it's like around 25% of patients are experiencing symptoms of 24 hours to at the most 36 hours of anything from pain at injection site to low-grade fever to muscle aches and just feeling like you have the flu for around 36 hours, but nothing beyond that, and it's clearing up. And I've heard that also. I haven't seen the data, whether it actually does interfere with the antibody response, but that's what the belief is right now. But that's, I would certainly, if you're having some symptoms, I would wait the 6 hours on the day of the injection and then take the Tylenols work well for me, or take your little Advil, and it's nothing serious, but again, it can put you in bed for 24 to 36 hours, around 25% of the cases.
After someone gets vaccinated, what should their daily lives look like? Should they still use precautions, go back to normal after they're vaccinated with the second vaccination?
Well, again, as I said, I think we got to start letting our guards down a little bit. I think you might want to know who's been vaccinated and who hasn't been vaccinated. I think you can be I think you can be cautiously careful. I think the things, and it depends on where your comfort zone is. As I said, we're really over the next 1 to 3 months going to be looking at the numbers to see, one, whether the numbers continue to decline as you would expect with the vaccination numbers. And if the numbers start going up again, that's going to suggest that these other strains are a problem. And the other thing is whether people who are who have been vaccinated are getting reinfected, to what degree. We're going to learn that. But I think at the same time, I think we have to start we have to start taking care of ourselves. So I would cautiously, in small groups, get out and start doing your things. Make sure you're getting your exercise. Make sure you're socializing in small groups, and try your best to be around people who are asymptomatic and who have been vaccinated. And we're going to know, I'm hoping know a lot more again in the next several months to be able to answer that question a little bit more definitively. But people are starting to do their thing again and going out and going on short trips, going to visit families. But again, in small groups. I still wouldn't go, out in large groups out in the community at this point in time yet. But cautiously start being a little bit more careful and visiting with families if they've been vaccinated, and things such as that. Keep wearing your mask and keep social distancing, but at the same time, starting to get out and be around people a little bit more, and just hopefully we'll have a more optimistic answer to that in the next couple of months.
Seniors and communities, when then can they expect the restrictions to be lifted? Since seniors
the answer is the same to that as to the first one. I mean, it's. I was glad to hear that your staff members are getting vaccinated. That minimizes at least the risk, But from the initial strain. But again, if these other strains are going to start becoming a problem, staff members can potentially bring those in from the outside, and that's again going to we're going to be able to answer that better in the next month or two. But again, I think again, as long as we're social, and unless there's some change in the numbers, which we're getting pretty much on a daily basis on the news or weekly, and as long as the numbers continue to go down, I would cautiously start opening up carefully and keep social distancing, but start going with the important things with our recreational therapists, exercise, whatever hobbies bring the most pleasure to your residents. Make sure they're getting at least as best as you can do a moderate amount of social stimulation and exercise right now, and hopefully over the next month or two we're going to be able to do more and more of that.
Along those lines, Georgia ranks 46 in the country for vaccinations. Reports indicate that large number of healthcare workers are reluctant to get the vaccine, especially frontline workers. What is the solution to that? And does it have to, the population, be 70% vaccinated to achieve herd immunity?
And again, nobody knows the answer to that, but that's the number that's been thrown around is 70%. But the number of, you're saying the healthcare, not the doctors are not resistant to getting vaccinated. So if you're talking about, I'm not sure, we have to break down more who we're talking about. I know there's been the people that there's been an ethnic component to the comfort with getting the vaccine. In Europe, there's some numbers out that blacks were less likely to get vaccinated than whites, whether that was related to accessibility versus just reluctance or discomfort with the medical system in general remains to be seen. But again, I think it's an interesting question with the caregivers you have at assisted living facilities. What can we do to make sure those folks are vaccinated? I think that's going to be potentially important, particularly for these other strains, if the vaccines are effective against them.
Okay.
Yeah. But again, it appears that when the numbers I've been getting, the majority of the residents, I don't know what the numbers are at your place, but just about all the other assisted livings I've been talking to, it's been upwards of 80 to 90% of the residents have become vaccinated. Yeah. And again, most of the doctors I know I'm not picking up any concerns about the doctors. And as far as the safety goes, I mean, of the vaccine, where that debate sort of comes down is and this is derived from the numbers I gave you earlier, that from a short-term standpoint, I think now, globally, the number of people that have been vaccinated is probably somewhere close to 75 to 100 million people have been vaccinated, if not more. And again, so I think we can cautiously, safely say, unless there's some large conspiracy out there, that in the short run, outside of the group of patients who has 24 hours of flu-like symptoms, that the vaccine is a fairly safe medical procedure to have. Then you weigh that against, like I told you, that if you don't get vaccinated, there's a 25% chance you're going to have mild to moderate symptoms. And then there's a 25% chance that you're going to have severe symptoms needing to go to the hospital, and a chance you're going to have persistent symptoms 3 to 4 months out. And if you're 85, the chances are you can die from this thing is 20%. So, that's the best way you can sort of evaluate the risk-benefit ratio. The other thing that some people bring up is, long-term effects of the vaccine. And again, I can't answer that. There's been these ongoing debates about do vaccines cause autism and things like that. And none of the vaccines have been conclusively shown to have long-term side effects. And these vaccines aren't, as far as the additives and things that are in the vaccines aren't uniquely or distinctly different. So there's no reason to believe that they're going to be any more dangerous long-term than the other vaccines that have been out there. But still, there is that ongoing debate about whether vaccines cause autism in some people. But we just don't know what the long-term effects are, if any. But that's the debate. Knowing what we do know about what the virus can do to you without the vaccine, knowing short-term it doesn't cause any serious side effects in the vast majority of patients. There's been some isolated case reports of some things happening, but it hasn't been proven yet that those were related to the vaccine. Versus when you're talking about 70 to 100 million people, they got vaccinated. Things happen to those people medically. You got that many people, and to prove causally that it happened because of the vaccine, you just can't do that at this point because the numbers are so small of the adverse events.
Can the vaccine have any effect on blood pressure levels? And I heard it was not recommended to get a mammogram after the vaccine.
Haven't heard those yet. So
okay.
I haven't heard any effects on the blood pressure. There's isolated reports of everything. There was up in the AJC about a couple people that had their platelet counts drop again. But if you get a low-grade temp for 24 to 36 hours, your blood pressure might go up a little bit because of the temperature. But again, I haven't heard any reports of persistent effects upon blood pressure. That second wave of that group of patients who were severely ill and then get the second, after the pneumonia, you get that second wave of inflammatory problems. One of that subset are people that can get an inflammation of the heart called myocarditis, but haven't seen many reports of that recently, and how common that is, just don't know. But as far as blood pressure, I haven't heard or read much about that.
Can you tell me again where you published the article last March of 2020 that discussed the effect of COVID on those with the Alzheimer's?
Yeah, Melva's got a copy of it. It was published in the American Journal of Geriatric Psychiatry. And we've expanded upon it. We wanted to get it out quickly. That was the initial 4 patients, but we've since then followed probably around 100 patients with Alzheimer's, and the numbers are similar, that they present, again, with functional and cognitive changes before they have a fever or respiratory symptoms in a large number of the Alzheimer's patients. And like the non-Alzheimer's patients, 30 to 40% of them are still having decline. They haven't returned back to their baseline 3 to 4 months out.
Any other advice as far as seniors that are hesitant to get the vaccine? You've given us the statistics with the benefits and the risk kind of, but for people that are just hesitant to get it.
What I've said again, if you know the numbers, and I think it's going to boil down to individually just asking what their fears and concerns are, and just logically, trying to explain to them what the risk benefits are. Whether down the road there's going to be any further restrictions placed upon us by the government if we're not vaccinated, such as not being able to get on the airplanes or going to restaurants unless you show your vaccination card. I don't know where the country's headed with stuff like that, but I think we just have to just logically sort of sit down and go over what the numbers are that we know, and try to understand what the patient's individual fears or concerns are, and just leave it at that, and try to discuss it in a logical fashion is the best way to do it.
What about seniors with their families? When is it going to be a safe time for them to see their families and grandkids? I know children are less likely to carry it, and they'll probably be the last to get vaccinated. But when is it going to be okay for them, the seniors that have been vaccinated, to see their families?
Well, again, it's a two-way street. Then there's a wide range of symptoms here right now, because we're right in the infancy now, because people are just starting to finish the first wave of people are being vaccinated. But so there's sort of the camps are, if we've been vaccinated and if both sides have been vaccinated, I mean, the people are starting to say, hey, for small groups with family and stuff, I think it's probably okay now to start letting families reunite with their parents. But again, what we got if we decide to do that, I mean, the other way to look at it, if you wanted to be, more what the right word would be, strict, if you will, waiting until we have a better idea what these other variants are going to do, which would mean another probably 2 to 3 more months of status quo like things are right now. But those are the two options, and if we decide to let our guards down and start, say, letting our family members come in, then again, I would just, as long as the weekly numbers are not going up, if you're not seeing vaccinated people getting reinfected, then those would be then we could say, let's cautiously start doing this, although and just knowing that we're not fully aware of everything yet. And maybe we're never going to be. Maybe there's always going to be another new question. But the answer is somewhere between those two choices, waiting 3 more months and to see what we know about the new strains, and or starting to let families visit in small numbers, as long as the numbers are continuing to drop and we're not getting any reports of large numbers of or moderate to large number of vaccinated people getting reinfected.
I'm going to ask Amy, she's also one of the administrators on the call, if she has any questions or can think of anything else.
No, thank you. You covered a lot of our concerns, and I know everyone was really happy to hear this information today. So Jennifer, I'll let you wrap it up, and then we're going to, for anyone that wants any information on the property specifically on our communities, I will put up a slide at the end that has the contact information. And thank you guys so much for your time.
Thanks, Amy. Thank you, Dr. Figiel.
All right. Appreciate it.
There's going to be a link sent out, so you need a copy of this presentation. You are more than welcome to it. And y'all have a great day. Thank you.
Take care. All right. Bye-bye.